I'm going to introduce now Dr. Elliot Dinetz. He's a double board certified in family medicine and functional medicine, where he understood early on that this is true path for optimal health and longevity. After his training, he saw the real issues facing society's healthcare, that wasn't a lack of access or medications, but rather not targeting the root causes of health issues and over-medicating with one size fits all. He has set out to change this. Today, he is on the advisory board of the Age Management Medical Group, AMG, as well as contributing lecturer. He serves on the medical advisory board to Forbes Health and is also a contributing author to several magazines, including Psychology Today, which reach thousands of people looking for more answers. Dr. Dinetz was an early adopter of clinical genomics, uncovering the unique genetic strengths and risks a person has to customize a personalized health approach. This in conjunction with advanced biochemical markers and lifestyles modification. By targeting underlying issues at the root, is often able to wean people of chronic and harmful medications while restoring health and slowing the aging process. This approach strategically works on the gut microbiome, hormone optimization, and improving immune function. He dedicates time outside to practice lecturing to the other physicians on leading-edge clinical genomics, aging, and research, as well as community education on wellness, nutrition, and lifestyle. Please welcome Dr. Dinetz.
Hello, everyone. Thank you so much for having me here at the first Advanced Anti-Aging Summit. It's a pleasure and an honor to be here. And we've had some amazing speakers already. Typically one with 2 different lectures, but you know, it's already been so great. I can't wait to contribute to the amazing advancements that we now have today at our fingertips. Just by a show of hands, who here is familiar with genetics or clinical genomics and uses it in their practice? Okay, great. So hopefully this will bring new information to you who have, and really be a great introduction to those who have not yet. So without further ado, we'll be talking about matching DNA with interventions. In anti-aging and really leading-edge longevity care, we are optimizing health by personalizing it to each of our unique patients and their unique needs. So we'll be discussing nutrigenomics, or nutritional genetic information, in weight loss and reversing chronic symptoms or otherwise idiopathic problems that patients have, and how these can really be a tool for the future. I have no relevant financial relationships, of course, and just going on the heels of what Dr. Lee said, your genes are not your destiny, but they sure can be a great guide to what you should and should not be doing to avoid problems and optimizing your health. So some learning points here. How to avoid trial and error when optimizing weight and health. Who here has not had a patient who tried trial and error 1,000,000 times and didn't get it right ever, when it comes to weight or when it comes to some nutritional program or exercise? We're avoiding assumptions based on lineage. I trained in Georgia, and that's really the stroke belt, if people are familiar with that in the States. And people say, listen, my grandfather lived till 110 and he drank and smoked every day. And I look at them and I said, you want to take that risk without knowing anything else, if that you got that genetic lottery? And you know, really bring it into perspective for people. So this gives you answers there. We want to avoid confusing new fads. Let's see, it's at least 30 years that I remember how many different fads and diets that came out. And if they worked, we would have stopped looking, right? Because not each person responds to each certain diet, right? And what genes are crucial for certain diets, that's important too, we'll see. So we'll learn all of these things, including what to take home when looking at labs and how to unlock the secrets of our patient's health. I wish I could do this in Spanish. Perdóname, la próxima vez, maybe. Anyway, clinical genomics. This is the new frontier in personalized and precision medicine, I believe. And this is kind of based on this N of 1 medicine, which is the study and optimization of the person in front of you, not everyone. We're moving away from these large, randomized, different people in our population-based trials to really looking at the person in front of us. So let's do a little introduction. A gene encodes a protein. These proteins are enzymes and have different functions in the body. The genome, okay, or exome, or all the entire makeup of our DNA and those expressing those genes, are the exome. Alleles, these are different variations of our genes. Okay, we all know alleles. Okay, a gene can have many different versions of them. They can be your blood type. If you have a thalassemia, it could be your eye color. So many different ways that one gene can have many different expressions and characteristics. And one can lead to a pathology and one might not, or a strength. For example, a SNP, or a single nucleotide polymorphism, is just one base pair change, essentially, that can disrupt the whole coding of that protein. And these SNPs are what was responsible for making these alleles or changes in our DNA, and we'll be talking about that. So where's the evidence, right, before I go any further? Well, we have, thanks to computer technology and the amazing discovery of DNA, as Dr. Edwin introduced, over 17,000 genes, and their almost infinite combinations with the proteins that they make, we have things called GWAS, or genome-wide associated studies. These are tens of thousands, hundreds of thousands, but really more. Millions of people can be looked at to see if their phenotype matches their genotype. So like what disease they have, all in common, and then we look at their genes and say, okay, look what's coming up. And what better way of looking at pathology than to look at the reason for it, which is at the cellular level, right? We're going to talk a lot about that, so don't worry. Let's start with it. Obesity affects, I think it's more than 30% now. The research is a little lagging, but of the population. And what happened? Did genes change over the past half a century? No. But 4 decades earlier, it was so little. So we know the pesticides, the food, the GMO, the stress, right? But what do we also know? You look at one of your friends who can eat whatever they want and they don't gain weight. And you look at somebody else, if they look at a cheeseburger, they're done. They're on a diet for the next year. So that's because between 40 to 70% of the, of obesity epidemic has heritability contributions, meaning they are actually genes that say whether or not someone's going to have that happen to them. So that's very interesting. Common misperceptions is that exercise is a major component to weight loss. I don't know anybody who's not exercising after January 1st in the new year trying to lose weight, and they don't. Because, as you'll see, it really depends on your genes that can help with that. Nutrition, though, is far more important. And we'll see here, this is from a meta-analysis, okay? And we know that weight loss in the short term, at least under a year, all right, doesn't really compare if you did a behavioral program of exercise and nutrition and you just change someone's nutrition, they're both the same. But again, this is in a large review of all the studies. So we know it's not that strong, but we'll see who it works for just shortly. So we'll begin with the first gene that's really important in weight, okay? We all know why weight is important. Weight is associated with metabolic syndrome, chronic disease, fatigue, aging, okay? We also know over the past couple of years in the pandemic, those with more adipose or fat tissue suffer with more harmful outcomes because they secrete more inflammatory cytokines. So this gene, I'll make simple for everybody. I say STAT, this is important, okay? It's a signal transducer, meaning it promotes signaling changes throughout the genome, okay, and has expressions in a lot of places. But what's interesting about it is that it's in 40% of the population and has a big role in obesity. It signals the hypothalamus to play a role in leptin-mediated regulation of energy and body weight regulation. So that as well. We have having 2 or more of these genes, which is not going to be as common as 40%, you're looking at less than half of that, contribute to having a much larger waist circumference, okay, and adipose accumulation. Particularly, where do we find this? With saturated fat, red meat and cheese and dairy. A lot of people like those foods. So the more STAT genes you have, the more averse to saturated fat you are. So this data is now over 10 years old, and it's so important that we know about it, that if you look at all participants, if they have 1 gene, big deal. But if you have 2 or more, 3, look at the exponential, not exponential, but look at the odds ratios. Now you're going up above 2 to 3 times the chances of developing obesity in the central truncal area, according to the Journal of Nutrition, if you have this particular gene. So let's go into a case where I've seen something interesting with this. We had a 44-year-old white female with truncal obesity. She had a history of going from 120 pounds to 160 in her 30s. Claims diet hadn't changed much over the years. Breakfast with low-fat yogurts, keyword, low-fat, and occasional other dairy products. But she had a meal. She had a little meat with every meal she was eating. Not a drinker of alcohol, denies fast food, snacking, or stress eating. She's in her 30s, didn't have hormonal issues, including thyroid problems. And other than borderline hypertension that we see with people who are gaining weight, really she wasn't taking any medication. So on her physical exam, we saw some truncal obesity with a waist size of 32 for her, 32, 33. No acanthosis nigrans, meaning the strip in the back of the neck suggesting she's diabetic or has insulin resistance. And here are her labs. So we saw she's a little dysglycemic, but other than that, respectively, she didn't have any major contributing issues. So we took a look under the hood. We went deeper because she wanted a natural way of seeing, how can I lose weight? What's right for my body type? And we saw she had 2 different genes with these respective alleles for STAT3. And I told her, I'm like, your nutrition really adds up to this being a problem for you. Have you ever thought of cutting it back? Oh, well, doctors told me to change my diet, and I think I know what I'm doing. Well, now we have her genes, and we have the data, so I turned the picture to her. And you should see the way people look at you when they're really looking at themselves on a cellular level, on a genetic level. And she goes, okay. So with the help of our health coaches, we created a nutritional plan that worked for her. We cut back the cheeses and the meat for 6 weeks just to see how she did, and look, 10 pounds off right there. So this is a critical point or aspect of how you can personalize a plan just based on DNA to help with weight loss. But imagine the inflammation reduction there. How many more years gained? And this is what we should be doing. We can do some biological or chronological age epigenetic testing before and after and see improvement. So FTO is the next one. How do I get my patients and colleagues to know what this is? Fat turns on. That was I did come up with that. And some of the geneticists and people who come up with the panels really like that. So this was one of the first genes they discovered with over 20 years ago already with regards to obesity. So about 60% of the population have 2 copies of this, meaning one from each parent as an autosomal recessive trait. And it carries almost a 3-fold risk, so even more than STAT3 when you have 2 copies. Mostly seen in women, and it's involved in the fat cell differentiation between white fat versus brown fat. Does anyone know the difference? White fat, you can yell it out if you want to. Right, so you got your visceral fat, that's around your organs, that's more harmful. And then you have some brown fat, like bears have a lot of brown fat with mitochondria in it, so they can survive during hibernation. And this brown fat is really not the pathological kind, as opposed to the white fat or visceral. Think of it like white bread. You don't want any of that, right? Because that's what's loaded in carbs and other, metabolic issues as a result. So you really gain more of that with this FTO gene variant. So you also have greater appetite, but weight loss with exercise. So we see that. These are genes like, oh, okay, we have a way of helping these patients. So portion control and exercise, they do make a big difference. Individuals with this allele might obtain more benefits in reduction in food cravings by choosing a couple of things. Cutting a little bit back on their, plate size, all right, and higher protein food. So now you're starting to see what's right for your body type. Higher protein, got it, less fat, kind of like STAT3, and, trying to cut back a little on the calories, and it's so easy to do by just showing them what you could do with your plate and what you're used to. Another gene is called LEP, which just stands for leptin, and many of us here know about that. That's our signal to the brain to say, stop eating, you're eating too much, we don't need that much. And less than a third of the population are homozygous, but still a substantial amount. And the literature shows odds ratios for obesity. If you have this gene variant, okay, or allele, anywhere from 83% to 500% increase of obesity. So it's kind of like that leptin resistance we keep talking about. These are people who probably have this gene variant where they're just continuously eating, they snack, they don't even know they're doing it, like while they're talking to you. This is really important. And it makes me think about myself sometimes. If I'm eating a lot on vacation and I start not feeling full, and then I'm overstuffed, this is kind of where you're going in that direction. Some people just have that predisposition to, continuously eating and gaining weight. So we know it's in response to eating. It's released from stored fat to curb the hunger, and it encodes leptin. And that's the C allele associated with these levels that are either not targeting the hypothalamus to say, hey, calm the eating of the fat food. And it also is associated with the adipose size, quantity, and leptin, as well as leptin resistance. So you'll see bigger fat cells with this gene. And it makes sense, all on a physiological level from the genome. You're not getting enough of that signal. You're still hungry. You're craving certain foods. And that's what happens as a result. Here's another case that I had recently. A 45-year-old white male with truncal obesity. He's a busy executive, and he presents to DNA Review to see what he can do to help him lose more weight. I know him for years. He was thin as a kid. His whole family is thin, and now he's in his late 30s, early 40s, and he is not that kind of person anymore. He's always been more heavy set, in the past several years since he was, out of college, he was telling me, and just wants to know what it is, why, what can I do to make sure I can keep it off if I want to. And he heard of genomics. He's in the YPO, or Young President Organization. He's into all the latest and greatest. So in addition to longevity, he wanted to know what we could do about it. So this patient states the only time he was actually, right where he wanted to in recent years is when he was eating more plant-based foods, fish, versus carbs and meat simultaneously. So that gives you an idea, okay. But also when he was exercising. So he's somebody who overtly told me, when I'm exercising and eating right, I'm where I want to be. But I don't do those two things. So it's been a struggle to be, consistent because he's in development. So we said, okay, let's see what we find. He had 3 different genes with different alleles, or SNPs, as we were talking about, for FTO, fat turns on. So he's already predisposed to storing fat okay, in the white fat matter. He needs the exercise in that particular gene, right? And he is eating more fats and carbs. So he already knew the answer. But when we showed him also the LEP gene in the lower right there, leptin, he's homozygous for that, and he has 2 copies. And I asked him, do you snack? Because I never really asked you that before. He goes, I don't think so. And he comes back to me and he goes, actually, yeah, I do. How did you know? Well, I said, look, it's right there. And the snacking was really keeping him from optimizing his weight. So these are people who, can benefit from intermittent fasting, of course, or just plain control. There are supplements we can use with glutamine, prebiotics, and high fiber that can essentially help patients feel a little more full and not go through those kind of cravings that they have. So when we showed this to him, he understood exactly what he needed to do. And unlike other patients where we're patriarchal and we tell them, you need to do this, I just show them their genes. And then it's more easy to kind of have them make those changes. So sure enough, he did. And I didn't speak to him for a few months, but he lost all that fat. And he was like, yeah, I just made sure I had a trainer. I did it 3 times a week at least, and then a couple days I'm walking or doing something else. And I kept the overall eating to a minimum during those days by using that shake you told me about, and it was great. So he had lost, I think it was 25 pounds since last I spoke to him, just on that. Now, while this is great, this is all how you can utilize someone's own body to customize a plan. It doesn't, bypass the fact that we have all these great anti-aging and longevity peptides, hormones, and essentially targeting the root cause of the problem and helping people. These are all great adjuvants on top of it. What it does do is show the patient what's right for them so they never forget. Then we go into some incretin genes in weight. Are people familiar with incretin? Yep, the stomach hormones that trigger our body to say, I'm going to stop eating, or I'm going to, secrete insulin now, and I'm going to clean out the liver. These are very critical roles, and we have medications today that many of you use in that pathway. So just a quick review. Food comes in, then you release, GIP and GLP-1, just like the medications, GLP-1 agonists. And what do these do? Okay, lipogenesis, they kind of tell, fatty acid synthesis, pancreas, release insulin. It also tells the stomach to, hurry up and promote gastric emptying, right? As well as telling the body, hey, you've had enough. Kind of, again, involved in that leptin pathway we talked about before. It's another step before that. So when you have food, it kind of tells the body, get ready, here come the carbs. So we have this gene, which has a lot of data behind it, and is one of the earlier genes we found associated with diabetes, and then they really understood what it does, okay? And this inhibits the incretin secretion of these enteroendocrine hormones. So you're not getting that release of insulin. You're not getting the appetite suppression, and you're not getting the clearing of the liver. So lower incretin release is associated with such variants. We have that from these genome-wide associated studies I was talking about of tens and thousands of people. And it signals that obviously here comes the carbs like we talked about. But also it has a role in defective insulin exocytosis, right? Because it's decreasing insulin, so it's not having that role on the pancreas that it should to release insulin, okay, but it affects it directly. So how about for weight? We know how it works for diabetes. There's a lot of medications out there in the GLP-1 category, right? Everyone knows about the weight loss medicine Ozempic or semaglutide we use. Works like this. It's a great way. If they have this gene, it's going to work like perfect. But also with this gene, you don't just tell them you need low carbs or you're pre-diabetic. This study was interesting, that those with this gene variant who consumed only 20% of a diet consistent of fat versus double that, 40, showed significant weight loss. Why is that important? What diet's 40% healthy, even healthy fat? Does anyone know? That's when it's not right. So you know both carbs and keto wouldn't be right for this type of patient if they have if they have gene variants in that pathway, possibly. So what else do we know about weight loss in this category? A lot of people are using intermittent fasting, right? Raise your hands if you use that with your patients. Okay, more people should. Time-restricted feeding improves blood glucose and insulin sensitivity in overweight patients with type 2 diabetes. In that randomized controlled trial, they got off of their insulin, just from that. Therapeutic use of intermittent fasting for people with type 2 diabetes. This was a case series, and everyone got off their medicine. Pretty impressive. This is regardless of genes even. But there are ways that we can use this for patients who are like, I don't want to use medicine. Other things, supplements that are really impressive as an incretin mimetic to help if you have that TCF7L2 gene in the diabetic pathway is Humnena sylvestra. And in a review of the literature, it showed that these humnenic acids prevent absorption of sugar molecules by the intestine and leads to reduction in blood sugar levels. So we have human data on that. So another case report that's very dear to me. A 32-year-old physician with a body mass index of 21 presents with increasing fasting blood sugar and a rising A1C. He's active daily, no junk food, heavy bread, or high glycemic foods, no, but likes his sweets every now and then at night. But he does eat late, and at night he does like carbs, like pastas, but also saturated fat. So he denies any other symptoms of diabetic-related illness, and his labs are as followed. His CBC was unremarkable. CMP showed a fasting blood glucose of 94, so again, 85. Above 85, we're starting to see association with cardiovascular disease. We don't want that. But his A1C went from 5.6 to 5.8 to 6 and was going up in this thin body mass index of 21. Interesting, right? And this is over a couple of years. They checked the GAD65 antibody to make sure he didn't have, type 1 diabetes that you see in younger people, thin people. Because, interesting enough, his insulin was 4, and then it's 2. And next time it was like 1.8. That's low, right? So, didn't we just talk about how you don't produce insulin, and we're used to high insulin and obesity? So this is the skinny diabetics you have to be cautious of who have that gene. Had 2 different alleles for that TCF7L2 gene. There are a couple of these genes. So we had a long conversation with the person who's taking care of this physician, okay? Because this patient is me. And I was well on my way to diabetes and couldn't understand what was going on. So late night eating isn't for me, plain and simple. Found that out. A1C dropped below 5.4, and that was that, okay? But this is what happens. These are the people that are missed in our society. And this is how genetics can kind of help tease out what's going on with someone that's not necessarily responding, because they need a personalized plan. So now we're on to histamine and idiopathic symptoms, because this is something all of us see in our office. And it's one of the great masqueraders. Histamine can produce so many different problems, we'll see. But let's hear here. There's 2 pathways in it. And one is the H&MT pathway for most of the topical itchiness that people get, or the wheezing, sneezing, stuff like that. Then there's the DAO pathway. This is more in the gut, okay? And there you can see there are 2 different pathways. And you have more of the GI presentation with if you have a variant or multiple variants in the DAO gene. What are those symptoms, you might be wondering? Well, IBS with diarrhea predominant can be the result of histamine. Orthostatic hypotension, when you stand up and you get lightheaded. Lower blood pressure, and migraines. You can see all of those with DAO variants. So it's very interesting as a great masquerader to have genes to kind of help us guide care in a patient. Just some review here that this diamine oxidase helps, this enzyme helps break down histamine at the level of the gut, okay? And variants are associated with low enzyme activity, so it leads to this predisposition of histamine and histamine intolerant-like symptoms, with an increase in just migraine alone of an odds ratio of 1.68 in males and over 2 in females. So that's double the risk, right, in females of just having migraine because of histamine. It also, interesting, in humans we have data that shows that supplementing with diamine oxidase in these patients can reduce symptoms up to 70%. So they don't even have to cut back, because histamine's in a lot of food, everybody. A lot of food. Particularly the top, you have champagne, aged meats and cheeses. So say goodbye to your, Parmesan cheese and things of that nature. And people don't want to do that forever. Unless they're really struggling with a disease, then they have to. But if you have a supplement that can help that, now you're really being a leading edge doctor. So these are the most common foods that we see, at least in my practice: champagne, avocados, aged meats and cheeses. That's like hanging duck. And that's why, interestingly enough, a lot of the Asian population who are used to aged meats don't have this gene variant. So a recap for the people that want to know how bad is histamine in the body and what kind of diseases. Well, we talked about some of them, but did you know about having endometrial cramps, uterus, because it's responsive? Histamine directly affects that and can lead to estrogen dominance. It can lead to, obviously, respiratory tract problems, your skin issues, but also tachycardia and arrhythmias. How many people are getting ablations unnecessarily? That's what really got me, and that's why I like sharing this. But also the central nervous system, neurological diseases, bone marrow issues, right, in your blood count, leukocytosis, as well as the gastrointestinal IBSD we talked about. So this is a 38-year-old executive, presents one of my earlier patients with DNA, and that's how you knew it was right. The guy comes in and you really helped somebody. He said, I have seen a neurologist who, by the way, no more first-line therapy, the way I went to medical school and trained to try lifestyle first. They go right into prescribing beta blockers or calcium channel blockers for migraines, not even caring. Sometimes they give magnesium. But the neurologist tried everything, and he still didn't get that much relief and just didn't want to take medicine the rest of his life. He's not old. So he also had some sexual side effects from one of the beta blockers, I should mention. So he tells me it's no big deal. This is my wife's concern, who was with him. I get little headaches, okay, they're migraines, but I pop 2 Excedrin every day and I'm fine. I'm good to go. And I'm like, really? Because that's not good for you. We talk about gastrointestinal hemorrhage, kidney issues, cardiovascular disease. He was setting up for a life of problems, and we couldn't allow that. So while there was no migraines in his family he was aware of, there were some food allergies, and he eats well-balanced. He has a chef. What can you ask for? He has everything. He just doesn't understand why he has these. So we looked at his genes, and sure enough, he had a copy that 1/3 of the population had in the AOC1 gene we just talked about in breaking down histamine. So I said, let's do a trial. I want you to do a low histamine diet. And he looked at me like this. Those are a lot of the foods. If you've ever seen a low histamine diet, it's a lot of foods people like. They include strawberries, spinach, as well as wines and aged meats and cheeses. It's a lot of different categories. So I said, all right, be conscious of it, and I'm going to give you diamine oxidase to help with that. So he said, sure. Didn't hear anything about him. I was nervous because I didn't want him to go down that path of taking Excedrin. So I have a follow-up reminder in 6 weeks, and I called him, and he was kind of laughing on the phone. He goes, I didn't listen to any of your diet advice, right? But I haven't taken an Excedrin since. And sure enough, 3 years later this year, he hasn't, and he has no more migraines. So very critical cases where histamine can present in so many different ways. If you can find that out in your patient, you just save them a lifelong complications of chronic disease and problems and symptoms. And again, with nutrigenomics, you can help people understand what they can eat and what they should avoid. And then it doesn't become so patriarchal and you're a team. So basically, when certain nutritional and lifestyle, modification, they not only lead to weight gain, but they can cause systemic inflammation, and it goes unresolved. And what does that lead to? Aging. And that's what we're here to prevent. So genetics can play a crucial role in unveiling that mystery and ultimately putting the pieces of the puzzle together to help our patients live better, longer. And that's sort of my wellness triad. You got to have the exercise, decreases all-cause mortality significantly. Each metabolic equivalent, or MET, that you increase is 12% decrease in mortality alone. Then we have your genetics to see what's right for you, and mind over matter. Of course, stress and enjoyment in life are critical, keeping that cortisol low. Thank you, everybody, and I'd be happy to answer any questions.